My name is Erin Carey. I'm the Division and Fellowship Director of the Minimally Invasive Gynecologic Surgery Division. Endometriosis is where small endometrial-like, or tissue that's similar to the lining of the uterus, similar tissue grows outside of the lining of the uterus. It can grow in anywhere in the pelvis, so the peritoneum, or the little thin layer that lines the abdominal pelvic cavity. It can grow on the organs in the pelvis, so the bowel, the bladder, and rarely it can grow in remote distances, so the pleural cavity, like the lungs, brain, very, very rare. Adenomyosis is where similar endometrial-like tissue grows into the outside of the lining of the uterus, but into the muscle of the uterus. While they sound like they are related and they can coexist, they're actually not related. And so I think that sometimes people think, oh, if I have one, I may have the other, and that may be true, but they are actually very independent disease processes. Endometriosis is considered a benign condition. That means not cancer in most people. And so I would like to just start out with that. It is associated with pain and infertility. And about 10 to 15% of reproductive age women will be diagnosed or have symptoms of endometriosis. Typically, patients will have severe pain with their menstrual cycle, but they may have pain with their menstrual cycle and also outside of their menstrual cycle, and they may also have pain with intercourse. So those are kind of the three ways it may present. Of women who are struggling with infertility, a significant number of those patients may also have endometriosis, and it can impair fertility in a variety of ways. Endometriosis is a chronic condition, so there really is not necessarily a cure for it, but it can be managed through a combination of medicines and sometimes surgery. And so depending on the patient and the stage of disease, we can identify the best treatment plan for that person. We do know that because it's a chronic condition, it may recur even if you go in and surgically remove the lesions. So we will use surgery for both treating patients who have pain and then also for improving fertility. We also just in general look at all of our patients who have pain complaints with endometriosis. We're going to encourage patients to improve their sleep hygiene, exercise, manage stress. All of these things we know impact the way we process and perceive pain. And so endometriosis is one of those mechanisms. So we will encourage medicine, maybe some surgery, depending on the patient's goals and disease state, and then some of these other treatments that are really important for patients' quality of life. Adenomyosis is the primary way we treat adenomyosis for patients who desire retaining the uterus, or maybe wanting to use the uterus, or just not planning to use the uterus but do not want to remove the uterus. The first-line treatment is actually a levonorgestrel IUD. So it's going to be a hormone-containing IUD that's placed usually in the office setting, and there's a lot of ways that we can reduce pain associated with office-based gynecologic procedures, and that can provide some local hormone therapy that is very soothing to the uterus and extremely helpful for patients who have adenomyosis. Cure for adenomyosis, so I mentioned there's not a cure for endometriosis, but there is a cure for adenomyosis. This disease is confined to the uterine body, so removing the uterus can cure adenomyosis. So it can actually improve symptoms. Certainly not an option in patients who desire preserving the uterus, but it is associated with very high outcomes because you actually just completely remove the disease itself. Sometimes we'll use oral medications or vaginal medications to improve pain with endometriosis, adenomyosis. One of these medicines we use are a group of medications called skeletal muscle relaxants. While these are not classically indicated for gynecologic diseases like endometriosis and adenomyosis, because these are affecting the uterus, which is a smooth muscle, there is referred pain from the reproductive organs to skeletal muscles, both in the pelvis, the low back, and the abdominal wall. So oftentimes, if we are trying to, in addition to possibly using hormonal medication, maybe physical therapy, we may also add a skeletal muscle relaxer, either orally or vaginally, to help with some of that referred pain. And then similarly, you can have the pelvic floor muscles respond to endometriosis or adenomyosis that's causing pain in the pelvis, and the muscles will not learn to relax until you teach them to relax, even when you treat the primary disease. So that's why sometimes we will have you do physical therapy before or after surgery, or before or after another medical intervention, in order to improve the muscle outcomes. They don't get the message, and so you have to teach them how to do that. And then with physical therapy, we may add a skeletal muscle relaxant to help those muscles understand how to relax. In addition to hormonal medications and surgery for endometriosis, there are other treatments that we will utilize with patients to incorporate to improve quality of life. We really are the pelvic pain experts in the region. Our surgeons are trained in both minimally invasive gynecologic surgery and emerging surgical techniques, but also with a very deep understanding of the pathophysiology of pelvic and sexual pain. And having the combined approach of thinking about a patient, I think, very holistically, including your goals, treating the disease, and also treating the other parts of the body that responds to the disease in the first place, sets us apart. If you're a prospective patient for our team, I think coming to our division with a really open mind, and that's not acknowledging any negative experiences that you've had in the past, which I think are pretty common, and we see a lot of patients for second opinions, third opinions, but really coming to the team looking for a partnership, wanting to walk some of this journey with us. The conditions we treat often are chronic, right? These are lifelong, and you could have periods where you may improve, and then periods where we may take a couple steps back. And so I think knowing that you have a good foundation, a sounding board, a team that is very well versed in kind of how these diseases progress, how they affect quality of life, how you may be affected not just physiologically, but also mentally and physically. I think all of those things coming together, it definitely sets us apart from other teams. It really is a team approach. So in addition to the surgeons, we have our surgical fellows who are the best and brightest applicants in the country who match with our team, which is really amazing. And then our very strong advanced practice practitioners who work with us, our strong nursing team, everyone who's specialized in this area. You know, one of the things that's important to know is this is all we do. All we do is gynecologic surgery and management of pelvic and sexual pain. And so we don't do routine gynecologic care. We don't deliver babies. This is our subspecialty, and we are all trained to care for complex patients in this area.